There are a lot of conferences and everyone gives lectures and data, but this is one of a kind where you go in hands-on, using the new technology, experimenting it, getting a feel for the technology, and learning hands-on exactly how these procedures are done and why this technology is so important.
The ISCVS symposium that we are holding here at Methodist Hospital in Houston, Texas, is the largest hands-on symposium in a variety of interventions in the world. It has not been done or achieved anywhere else. This is something that's so unique because we have here state-of-the-art technology, the newest innovations in endovascular field to train and teach physicians how to use and implement this to provide better patient care.
having such a great wealth of resources and having different x-ray techs at every station, having all of the equipment available to do the jobs that we wanted to do, it was really a great opportunity. It was like having a big endovascular playground where you could test out all of the different equipment in a controlled environment. As a physician assistant, being able to work with the different surgeons and really grow my depth of experience has been a great opportunity.
Well, there's certain things that you can't learn in the classroom, and obviously when you're working as a clinician, the mistakes are costly. So here you can experiment with the devices, you can try things you've never tried. You have experts kind of guiding you and giving you advice as to how to deal with complications and procedures, and that's always what I'm looking for. I'm always looking to increase my speed of learning and content, and I think that this hands-on approach is very effective for that.
Good afternoon. Hi, this is Khurram Nasir from DeBakey Cardiovascular Studio presenting live on the Multi-Modality Imaging Conference, and today I'll be presenting on the role of calcium testing in chest pain patients, Power of Zero Part 2. But before I go live, I just wanted to take a moment for everyone who is listening in today, locally as well nationally and internationally, all the healthcare workers who are fighting one of the most unprecedented crises we are facing worldwide. I just wanted to thank all the efforts of everyone, as well as praying for those who have selflessly given their lives and continue to come onto the battlefield. Just a message: be safe, everyone out here. So also I would like to give you a message that as part of this live web, we'll be taking questions at the end, and you can text DeBakey to 37607, online poll v.com @DeBakey, and we'll be taking those questions live. So when I got this offer to present today, I just wanted to bring in some of my own personal experiences and the issues that we deal in real life while making those decisions with patients presenting with chest pain. While we have heard extensively about the role of Power of Zero in asymptomatic individuals, the question is, does it really have any application in chest pain patients? So jumping on to a regular case that we would see most of the time, I had this opportunity to see this patient a few years back, almost 60 years old, dyslipidemia, hypertension, well controlled, non-smoker, has a family history of CVD, presenting with chest pain on exertion but also at rest and stress, and at times relieved with rest. Not really typical chest pain symptoms. Based on the pretest probability is of intermediate risk. Now, as part of the guidelines and class 1 recommendation, the patient underwent a stress myocardial perfusion imaging, did almost 9 minutes, close to 10 METs, and a normal myocardial perfusion imaging. So the question really to move ahead here is, how usual is this situation? Let's say we ask you that in the next 2 days, there are going to be 100 cases who will undergo stress myocardial perfusion imaging. And if you just call them normal, how accurate would you be for all without even having a look? So to answer this, I would refer you to a landmark paper from Alan Rosansky and Dan Berman that looked at actually the trends over the last 2 decades. So for example, if we were in 1991, almost 40% of those tests done would be abnormal, and there would be ischemia in close to about 30%. Now, fast forward that to 2009, maybe the changing dynamics of coronary artery disease, better treatment, or a more wider population that we are catering to right now, that there is only about 10% of abnormal and 5% ischemia. Now, one can argue that these are not contemporary numbers. For that, if you look at the PROMISE study that recruited almost 4,800 individuals in the CTA group and close to almost the same in the functional testing group. Majority of them pre-test probability was intermediate with an average of 53%. Even in that population, almost about 1 in 10 had any abnormality on the functional testing. Now, when you're talking about abnormality on the CTA, it was about 10% as far as obstructive disease is concerned, but still close to half of them had some underlying disease. So the question really for my end is, when I'm performing SPECT myocardial perfusion imaging, I always tend to think, how would a coronary artery calcium test would be helpful as a marker of early atherosclerosis and burden? Can it supplement in my decision making? Can it supplement in how I manage the patient? Can it supplement in how I think about the risk of this patient? The first question really what you need to ask yourself is, how often would you see an abnormal calcium study? Or those presenting with high calcium scores, out of 100, how many of them would have calcium score greater than a 0? Or let's assume significant atherosclerosis greater than 100 or 400. In this regard, a few years back, Alan Roszensky and group did a meta-analysis that was published in JACC Imaging, and accumulating data for almost 20 studies, more than 7,000 patients. Almost half of them they were looking for those who were normal myocardial perfusion imaging. They showed every 3 out of 4 patients with a normal perfusion imaging would have a positive calcium scan. And actually, 1 out of 4 would have a calcium score that is greater than 400, which we now is significantly associated with a very strong adverse event. So moving on from here. Now the real question is, if you would have that information, would it influence your interpretation of a SPECT myocardial perfusion imaging? Now, while many of my colleagues would say no, however, in a very interesting study, Morden et al., I think so the paper was published in 2010. They selected close to 150 patients who underwent SPECT myocardial perfusion imaging as well as simultaneous calcium scoring. The myocardial perfusion imaging was visualized in 2 separate sessions. First, without the knowledge, and second, then with the information of calcium scores. And myocardial perfusion imaging was categorized into 4 groups: normal, equivocal, ischemic, and fixed defects. So if you look at this data, in absence of the calcium score, almost 21% of the studies were called equivocal, and then about 38% were ischemic. Now with calcium score, there was a significant reduction in how these studies were classified equivocal, and actually a 10% absolute increase in the incidence of ischemia. Overall, just having the information of calcium score at hand before the myocardial perfusion imaging interpretation change your decision about the study in almost 1 in 3. So while we speak about more subjective interpretation, one can argue we are more interested in more objective diagnostic yield, and does it really make a difference there? To address this question, Slomka, Dan Berman at Cedars-Sinai basically enrolled almost 150 simultaneous patients who underwent hybrid rubidium PET-CT scans and also had invasive angiography over the next 14 days. And myocardial perfusion imaging was quantified automatically for LAD, the CIRC and RCA, and they calculated the ischemic total perfusion deficits for almost 450 vessels, and then they compared it with the burden on obstructive disease on invasive angiography. And as you can see in this graph, almost 1 in 4 or higher individuals who had a calcium score greater than 100, but a normal perfusion that's detected as less than 5% of the total perfusion imaging defect were found to have obstructive disease. So not only the knowledge of presence and higher burden of calcium improves your subjective interpretation, but also improves the detection of actual coronary artery disease. Now moving along, while the diagnostic implications are real, in the end it all depends what's your prognosis. So one should truly ask the question, what's your risk? If you have a normal perfusion imaging and have a high calcium score, that's almost seen in 1 in 4 of these individuals. Again, coming back to the landmark paper by Alan Rozansky and Dan Berman, where they looked at almost close to 1,000 individuals who had a non-ischemic study on perfusion imaging and followed them for close to 32 months, you can appreciate more than a half of these individuals had a calcium score greater than 100. Almost 1 in 10 had significant atherosclerosis and a calcium score greater than 1,000. Now, in a follow-up of 32 months, the event rate went up from 2 to 16%, almost 8-fold. And if you still focus on just sudden cardiac death or myocardial perfusion imaging, whereas with the calcium score of less than 100, you see no events, it goes up to as high as 2.5%. And also confirming these findings in the landmark study by Dr. Chang and Dr. Memarian at our group that clearly showed that individuals with high calcium scores, even in absence of ischemia, for example, those with calcium score greater than 400 without ischemia, the risk is almost equivalent to someone who presents with a high score of 100 to 400 but has underlying ischemia. So this is critically important that as we are looking at these individuals, we tend to assess their underlying atherosclerotic burden that can supplement information about your perfusion imaging. At the same time, while we have seen that not only the knowledge of presence and burden of calcium score on top of myocardial perfusion imaging improves your subjective, objective, as well as the prognostic value, in the end, we are not going to make a change unless it can influence management decisions. For this, Timothy Batman group identified almost 700 consecutive patients without known coronary artery disease, less than half of them on aspirin and statin, who had a normal rubidium scan and also in the same setting had a calcium score. Almost 24% of them had a calcium greater than 100, and as you can see in setting that there was a almost 3-4 doubling of improvement in any medication use with a calcium score of greater than 400 as compared to calcium score of 0. So just to summarize this, and I think so this concept of simultaneous information of atherosclerosis burden while patients are being pursued with stress myocardial perfusion imaging is useful is catching up, and there is a lot of consensus among that, and I think so there is huge value proposition in this era knowing about your calcium score, especially if you're pursuing stress myocardial perfusion imaging, as almost 2/3 with normal studies will have missed subclinical disease. Now this is critically important, as you can see it improves the diagnostic interpretation of obstructive disease, it leads to better prognostic information, but more importantly we are now seeing signs, strong positive signs of enhanced downstate preventive therapies. However, at the same time, while I think this combination works and using, especially when the stress myocardial perfusion imaging is abnormal, I just wanted to open up another Pandora box. I think now we see with reducing disease burden, the likelihood of obstructive disease is less, and even in CTA, when almost 1 in every 2 studies is called normal, I think it's worth that we can ask this question, are we doing too much advanced imaging testing? Can we have a staged approach? Can we have an additional gatekeeper in addition to the inefficient clinical pretest probability that we employ right now? In my view, the characteristics of a gatekeeper in this low-risk chest pain patient should be that it's widely available. I can get the test done at 2 a.m. or 8 p.m. It's economically feasible. It doesn't cost hundreds of dollars. It's a straightforward evaluation that may not require specialized interpretation. It's extremely safe to undertake and absolutely accurate. So, I'm sure you would have guessed where I'm going, and I'm saying, well, can power of zero be a solution for this problem? And the reason why I bring in again is 10 years ago, with peers all across the country, in this landmark paper on diagnostic and prognostic value of absence of coronary artery calcium, we came up with these 4 main findings, apart from confirming the value in asymptomatic, that there is a power of zero even among those who present with chest pain. The literature reviews showed us that even in this patient population, if you have a calcium score of 0 in the next 4 or 5 years, you tend to have a favorable prognostic value. And based on studies of individuals who were pursued with invasive coronary angiogram, we found out that they have a very high negative predictive value of ruling out obstructive disease. Had a low prevalence of ischemia. We couldn't discern between mild to severe ischemia. And in a small set of studies of almost 400 individuals, very reassuring of a 99% negative predictive value even in low risk acute chest pain patients. And as a result, in the next few years, in 2010 and 11, we came up with some ideas in how it could be incorporated in the chest pain evaluations. For example, you start with the pretest probability and just focusing on the low likelihood, even ignoring the intermediate. Starting with the calcium testing would be reasonable, and if it's 0, it's a good rationale to look for non-cardiac reasons. And if your calcium score is very high, greater than 400, there's no reason to pursue any advanced imaging. Proceed with invasive angiogram. And in the mid-range, 1 to 400, higher the calcium scores, where it becomes a little challenging with the blooming artifact, a myocardial perfusion imaging. And if you are in the low range, a coronary CT angiogram would truly be a great second test of choice. However, at that time, I did not realize that the backlash will be fierce and intense, and even the guidelines had something else to say about that. For example, in 2012, the ACC/AHA guidelines for the diagnosis and management of patients with stable ischemic heart disease downgraded the utilization of calcium testing in these patients from a 2A in 2007 to a 2B. The appropriate use multi-modality criteria that came out in 2013 suggested that calcium testing in these settings is rarely appropriate. And in 2013, the European guidelines for the management of stable coronary artery disease actually gave it a class 3 recommendation. And even the more conservative guidelines from our peers across the border suggested that absence of calcium does not rule out coronary artery stenosis in symptomatic individuals, and thus of little value. And as I started looking into that, it became very clear that this was an uphill battle. We truly have to move a mountain. And almost on a regular basis, from my friends and peers and everyone across the world, every time there is a case report published of a significant atherosclerosis with a calcium score of 0, I can tell you that I do get that information. And really, our community is rightly so questioning, if you have a calcium presenting with chest pain, is calcium scoring dead on arrival? So let's take a break here and ponder and the uncertainties around it. So how do I move ahead in trying to convince you that there is more to what meets the eye here? So I'm going to try to investigate the uncertainties here, and through a critique of this famous scene from the pop culture movie Matrix that was released in 1999. I don't know if a lot of our Generation X would even know about it, but it left a huge impression on me. Now, here's Neo. who's a computer geek, he discovers discrepancies in the world he's living and start questioning his own reality. He meets up Trinity that ends up bringing him to Morpheus. And this is where Morpheus really asks the key question about the blue and the red pill and says, well, after this, there is no turning back. You take the blue pill, the story ends here. You wake up in your bed and believe whatever you want to believe. Now, if you take the option of taking the red pill, I will show you how deep this rabbit hole goes. And remember, all that I'm offering here is the truth, nothing more. So are you ready for this journey? Let's start. So the first biggest concern that always comes up by our peers, the guidelines, is that the calcium testing does not reliably, it doesn't say always, but says reliably excludes significant coronary artery disease. And last year there was this heading at TCT MD after umpteenth paper showing that a zero calcium reliably excludes coronary artery disease among stable, but expert debate was still there. For example, my mentor, my friend, and one of the leading figures in coronary CT angiogram, Stephen Achenbach, who's going to be the president of ESC, said that, well, if your patient is presenting with typical symptoms and the calcium score is 0, I would still do a CT angiogram, and a calcium score of 0 would not suffice. And I couldn't agree more, Stephen. And actually, I can give you an example of yesterday where a patient who presented to my clinic in the mid-50s, even in these circumstances, with typical chest pain, and rather than pursuing a CT angiogram or even a stress test, I actually sent him directly to Dr. Shah. And what we found was a 99% long eccentric ulcerated lesion. He got stanted, was discharged the same day on Brilinta, high-dose statin, and aspirin. So let's be very clear that we're not talking about unstable, high-risk chest pain patients. We're talking about low-risk stable patients, and that's where I quietly question that. Does everyone with a low risk or atypical chest pain patient should pursue with the CT angiogram, or can we think about the calcium as a gatekeeper? And the reason is, working with 3 of the smartest folks I know, Mike Blahar, Roger Blumenthal, and Matt Budoff, we clearly came up in this 2011 paper, where is the utility of 0 calcium score as a prognostic test in chest pain patient? Not those with typical chest pains, unstable angina, positive troponin, or abnormal EKG. Actually, the value lies who are at the low intermediate risk individuals. So the question moving ahead, is there the power of 0 holds in the low intermediate risk studies? And for that, I'm going to refer to one of the most famous study in this space by my friend Todd Villanis, past SCCT president, current chief editor of JCCT, where they looked at 10,000 patients in the confirmed trial. Only about 16% had significant stenosis on CTA. By the way, half of these individuals had a calcium score of 0. And even to date, he and I and Aresta, we continue to debate, very friendly banter, on whether this means anything. So it depends which side of the bed you woke up. Either the glass is 97% to 99% full, or 1 to 3% absent. And when I asked Todd last year, since this was for the all population, what would happen if you focus just on the low to intermediate risk? His response was, well, the negative predictive value is likely going to be better for low risk patients. The same findings were subsequently in the last couple of years confirmed by Matt Budoff and Udo Hoffman from the prospective PROMISE study, although it was randomized them to CT angiogram and stress imaging, functional testing. Calcium testing was done. Almost half of them had a calcium score of 0. In that arm, the negative predictive value was as good as close to 100 of 98.5% to 99.5%. That led them to come up with this conclusion that given the low prevalence of obstructive disease, as I have pointed out, the optimal diagnostic strategy can be a calcium as an initial test followed by a second test. And the very high sensitivity of calcium testing for obstructive disease and cardiovascular events supports the use of calcium as a first approach, as was also done in the Crescent study, which I'll show you around. However, at the same time, I still get the concerns that a calcium score does not have the same short-term favorable prognosis in symptomatic patients. So I'm not looking just for obstructive disease. I'm looking for prognosis, and the concerns comes on from this confirmed study that showed that with individuals with calcium score of 0, almost in the next 2 years, the event rate was 0.9%, almost 44 individuals. But mind you, if you look the data carefully, more than half of this, 24 individuals, these events happened in those who had a normal CT angiogram. And by the way, less than 10% of those events were revascularization. And suddenly when you have calcium positive or higher, almost 70% of those events become revascularization, clearly an indication for an oculostenotic response. Now let's assume how many individuals we would need to scan to find one at risk. Almost about 340 to find one at risk for revascularization, almost close to 1,000 for myocardial infarction, and about 1,600 one at risk of death. And even if we assume a 30% reduction in myocardial infarction, we need to scan 3,000 individuals to find where we can truly make an impact. Now, that's something that as a society we need to take a step and ask ourselves whether it's worth it. However, more reassuring data also came in from the UK when, for a temporary period, the NICE guidelines adopted utilization of calcium testing as an afferent. And in this study, where about close to 300 individuals underwent calcium testing as well as CTA, 60% low risk had a calcium score of 0, that's 6 out of every 10, and almost 1 in 2 at intermediate risk of chest pain had a calcium score of 0. And when these individuals were followed for almost a year and a half, only 2 patients died of cancer. And how many individuals with a calcium score of 0 had an event? The answer is 0. And now I would like you to refer to this fantastic Scott Hart study that has given us so much information about the value of CT angiogram as far as the prognosis and intervention and what the outcomes are, and led by Michelle Williams and Ed Nichols. They, in this recent paper, they looked at actually high-risk features, positive remodeling, low attenuation plaque, spotty calcification, napkin sign ring, and asked the question, how good are they prognostic? While they were highly prognostic for adverse events, if you look at the data of how many individuals had no events in 3 years. So if you had no plaque or no high-risk features, 99% of people did not have an event, only 1% events. Now you would ask, 2% of individuals with calcium score of 0 had these features. What was the event rate? Actually, if you had a calcium score of 0, 99% of individuals had no event. Same favorable prognosis as a normal CTA, as high-risk plaque features. Actually, if you take all the information together, presence of adverse plaque, obstructive disease, risk scores, and put them in a box and shake it up, the only one thing that would come out that would give you prognostic value is the burden of disease as identified by the coronary calcium score. As a result, in this editorial commentary from 2 past SCCT presidents, Dr. Shaw, Dr. Jim Min, and current president, Dr. Ron Blankston, they came out with a suggestion that an important subgroup is those at a very low risk, are those with a calcium score of 0. And even this finding from Scott Hart strongly support the role of calcium scoring alone as a mean gatekeeper for selective use of CT, especially as what we have pointed out in those with the low pretest risk score, not those with high risk, unstable angina, positive troponins, or abnormal EKG. Well, while we have clearly showed you that the risk of obstructive disease is almost non-existent, there still remains some concerns about can calcium score reliably exclude ischemia. In the first meta-analysis that was published in 2009 from 8 studies with almost 3,500 patients, we showed that almost about 7% individuals who had ischemia positive on perfusion imaging had a calcium score of 0. We were truly unable to discern whether it was mild, moderate, or severe. Just a few years back, now almost 12 more studies, more than 7,000 patients, Dr. Rosansky's group has found the same frequency, about 6.5%. And although they tried a little bit there, but the information wasn't out there. So the question really for us in clinics, while we're seeing these patients is, well, you have these 6% individuals who have an abnormal, with an abnormal myocardial perfusion imaging have calcium score of 0. What's actually the risk? Are they safe? So like to point you again to Alan Rosansky's and Dan Berman's study, where they looked at individuals who had ischemia positive, and in mean duration of 32 months, when they had a calcium score of 0, there was only one early revascularization and no cardiac death MIs, or the event rates were almost 0. Now, in a much larger study published a few years back, Engber's group looked at nearly 5,000 individuals. 91% were intermediate risk, and followed them for 5 years, where overall 6% people had MACE events. Now, consistent with what we've seen in the past, 6% individuals had a calcium score of 0, but they were able to classify them. They were likely to be exclusively mined. And if you look at the event rates, actually, among with the calcium score of 0, there was no difference if you had a mild ischemia or not. Very reassuring finding that the prognostic value still holds, the power of 0 holds even if you had mild ischemia. And you don't have to take my word. Engber said, when performing SPECT myocardial perfusion imaging in patient with 0 calcium, you must be aware that an abnormal myocardial perfusion imaging results are more likely as a result of false positive findings than true perfusion abnormalities. And they go even a step ahead, and that says that addition SPECT myocardial perfusion imaging with a calcium score of 0 could result in unjust invasive imaging with additional cost, risk of complications. Therefore, their conclusion is SPECT myocardial perfusion imaging is not useful if you have a calcium score of 0. And when my mentors and sages, Alan Rosansky and Dan Berman, comes and give a recommendation, who am I to disagree when they say there is, with calcium score of 0, there is a low likelihood of atherosclerosis and myocardial ischemia. They are asking us to refer these patients away from advanced imaging tests. So I'm not going to question their judgment here. Well, even if you provide this data, you continue to go down this rabbit hole. I have received concerns that the power of 0, well, it's great. It may give you some more information, but we are in for the long term. Well, actually, there is a paper that addresses this, and Ed Nichols and Adam Timmis group took 3,000 patients who were referred for CT and also got calcium testing. As we have known, 1 in 2 of them had a calcium score of 0. I'm already getting sick of telling you about the negative predictive value of calcium score for ruling out is almost as good to 100%. They followed these individuals for 13 years. And how many of these individuals had a cardiac death? 0. 0 patients with power of 0 died of a coronary event in the next 13 years. And actually, they came back with a much more stronger recommendation and said the anatomic and prognostic data shows that a CT calcium scoring is a robust method for identifying low-risk patients. And they are also questioning the need for further testing when the score is 0. Well, in recent years, there have also been some concerns and raised that, well, why there is no clinical trial data on calcium testing as a gatekeeper approach. One of the key things is, if you look at all the trials, be it the ROMICATs or the Promises, unfortunately, none of them incorporated calcium testing as a gatekeeper approach. But kudos to Koen Niemann, the next SCCT president, who was brave enough and had the courage to design a study, a promise-like study where randomized individuals presenting with chest pain to the CT strategy or functional imaging. However, he goes a step further and in the CT strategy incorporates the calcium testing. And if the calcium score of 0, they actually do nothing. And by doing so, they were able to exclude almost half of the individuals who needed CT angiography. These individuals were followed for 2 years. And as you can see, the coronary artery disease was easily be ruled out with a calcium score of 0 in the low to intermediate risk. In a 2-year follow-up, they had no further testing that was needed in these individuals and had no adverse events. So now just looking at what Koen Niemann has to say, he says, well, the incorporation of calcium testing as a gatekeeper is justified in the CTA algorithm. It can avoid contrast in almost 40% of individuals, reduction in radiation exposure, cost. And this result shows there is no indication that the implementation of a calcium scan in patients with a low intermediate probability is unsafe. So a lot of tweets that I get with my friends, it's a friendly banter. This is not for symptomatic patients. I would refer you to Koen Niemann's study. The biggest problem concern I get when having these conversations is stable patients maybe, but somebody coming to an ED, low risk acute chest pain, nobody even wants to hear that. And I'm going to take you deeper down in this rabbit hole and say, in my conversation a few years back at SCCT, I did raise this question. And I said, I see a clear value of absence of calcium testing as a gatekeeper for more advanced testing, adding value to the majority of the low-risk patients in actually acute chest patients who are presenting to the emergency department. As part of this conversation, I was put to the task and says, well, do you really think that the finding of a calcium score alone when it is 0 is enough? Well, because yeah, it's true that the overall rate of obstructive disease is very low, but it's not 0. And we are speaking about safe discharge of patients. And I think it's not enough. And I was even put to task and say, how would I sleep if I send a patient with a calcium score of 0 home from an ED? So again, taking you back to that matrix analogy to the blue and the red pill question, and let's say we have a sage Morpheus comes in and said, here's 1,000 patients who presents with acute chest pain, negative troponin and normal EKG. I'm going to give you a pill, blue, test A, which is normal in 91% of times. However, nothing's 0. If it's normal, in the next 6 to 12 months, there is a 1.2% risk of having an event. And it has a pretty good negative predictive value of 98.8%. On the other hand, I'm going to offer you a test B, the red pill, which is normal in 65% and has a risk benefit. If it's normal, it's not 0, but it's going to be 0.3% and gives a significant negative predictive value of 99.7%. I wish I could see a show of hands here, but I assume as a patient, you would rather be reassured with the test that gives you a 0.3% event rate versus 1.2. But again, open to debate, open to uncertainties. And really, the Morpheus here is our own Dr. Mamarian and Neo, Dr. Faisal Nabi, and kudos to them for doing this study at Methodist, where they took almost 1,000 patients presenting to the ED with acute chest pain. All of them ruled out with a negative troponin and an EKG, and as usual, standard of care underwent stress myocardial perfusion imaging, but they added a calcium test. And as a part of that, what they found that less than 1% of individuals, half of these individuals, more than 60% had a calcium score of 0, had an abnormal perfusion imaging, but who cares? In the end, it's all about the events and the risk. And when these patients were followed for almost 7 months, 3.1% individuals had events. 1.2% individuals with the normal stress myocardial perfusion imaging within the range of our acceptability had those events. Pretty robust. This is the data that leads us to continuously consider SPECT myocardial perfusion imaging in the ED across the country. Very reassuring. However, when you look at the calcium score of 0, if the event rate in the 7-month follow-up was only 0.3%. So my response to the question is, how do I sleep well while considering discharging a low-risk patient with calcium score of 0 from the ED? Thanks to John and Faisal, I can tell them I sleep 4 times better. And not only this, there are other studies. For example, a Brian Jara group from MGH also looked at patients who underwent CT angiogram and coming with acute chest pain and found almost the same findings. If you incorporate that with the TIMI risk score, a calcium score of 0 with the TIMI has a negative predictive value for ruling out obstructive disease of 99.7% and with an ACS almost close to 100%. And they also kind of agree that in the real-world clinical scenario, identification of calcium score, testing that, it has an excellent negative predictive value, can easily identify those at the low risk, and has significant value in our real-world situations. So, when I presented this data and says, well, the risk of having an acute event or missing an obstructive disease with a calcium score of 0 is lower than a normal nuclear stress perfusion imaging or stress echo, which is routinely employed in this country. And even with this, if the question comes out among my peers that if the calcium scoring and patients in chest pain, is it dead on arrival, my feedback, and I say, go out with confidence and tell them that the calcium scoring in patients with chest pain is still alive and kicking. All you truly need is a little courage to accept the power of 0 and seek truth, because the truth will set you free. And really the facts are, number 1, absence of calcium score of 0 rules out with a 97 to 99% negative predictive value obstructive coronary artery disease. It rules out an ischemia with a negative predictive value of 99%, and even among the few, there is no extra risk. In real-world situations and clinical trials, 0 event rates are seen with a calcium score of 0 presenting with low-risk chest pain patients or atypical. There is 0 coronary death in 13 years. 0 events have been seen in a calcium score with 0 in RCT settings. The negative predictive value for ACS rule out, which is the main purpose in the ED patients for low to intermediate risk patients, is 99 to 100% and has a better prognosis than stress myocardial perfusion imaging or stress echo, which remains to date the standard of care in majority of the situations or institutions across our country. So, I'm just going to end up this slide presentation with, I'm sure, with some ideas. If one of my superheroes, I don't know if you know this guy, this is Wayne Gretzky. He played 20 sessions in the NHL for 4 teams from all the way from 1979 to 2000. And he's called the greatest hockey player ever, who scored more goals, more assists than any players, and actually scored 200 points in one season. And when you asked him about why is he so successful, his advice was, I skate to where the puck is going to be, not where it has been. And just an advice to the upcoming fellows out here, we are seeing a huge shift of the healthcare from not only the focus being on effectiveness, efficacy, quality, but value-based care. And I truly believe in the next 10 years, the healthcare puck will be in the value-based medicine corner. And when we're talking about value-based care, I don't think so we would be able to afford majority of our advanced imaging tests, be it myocardial perfusion imaging or CT angiogram, to come out normal. And I think that in the next 10 years, calcium testing will likely be a gatekeeper unless and until something else comes on board. So to end this, I'm just going to leave it here just because we have a nail, we have a hammer with advanced imaging such as myocardial perfusion imaging and CTA. Not every nail need to be addressed, and if you have a calcium score of 0, you can take a pause. Thank you so much, and we'll take some questions here. So I will start. There are 3 comments right now. The one says they keep on moving ahead, and maybe we can stop with 1. Okay. So we'll start with you. One comment is, I agree with you, but I can't reconcile that the fact that I have seen patients who have had a calcium score of 0 within the month who came back with an ST elevation. And I agree. As I said, as far as what we have seen out here is that individuals, there is no such thing as a 0 risk, unfortunately. And even with a normal CT angiogram, as shown in the confirmed trial, almost half of those individuals with a calcium score of 0 also had a normal CT angiogram. So, and the risk of a calcium score of 0 prognosis is much better than a normal myocardial perfusion imaging, which most of our physicians to date are very reassured. So if you look at the data, you will find individuals with a normal myocardial perfusion imaging, a normal CT angiogram, and also a calcium score of 0 coming back with an event. We cannot target black swans that. And if that's the case, then we should also not be reassured with myocardial perfusion imaging. So if you look at the data, they're pretty reassuring. I absolutely agree there are going to be anecdote cases. Of course, we need further investigations in trying to find that out. Okay. The next question is, does the prevalence of ischemia with calcium score of 0 change with age? So far, what we have seen is that's not the case. Unfortunately, most of these studies have grouped calcium scores and the spec findings together. A couple of them have looked by ages, but so far we have not found any discrepancies according to age. If you go up, yeah, you can go up. We can start here. Yeah. So this is from Rio de Janeiro, Kaiser. Congrats for the excellent lecture. We now know that a significant proportion of elderly has 0 calcium. No data yet available to justify statins, let alone aspirin. How would you consider preventive drugs in an elderly patient's atypical chest pain with a calcium less than 100? Same approach has been suggested by Mike McDema. So the first question is, Kaiser, this is really definitely the area that still remains uncertain. I think the best value of a calcium test in an elderly is if you have a calcium score less than 10. Studies from Bioimage from Dr. Fuster's group have clearly shown that these individuals have significant less events. Now, if you look at all the data that includes the symptomatic patients that from the PROMISE trial, from the confirmed study, although they have not looked at by aging, but all through on the low risk individuals, it's very reassuring. One of the challenges that happens is as you age, with any symptoms, there is a likelihood that you may be considered higher risk. So those are great questions, and I think so a great opportunity for us to look deeper into confirmed study, the bioimage study, as well as the PROMISE to answer some of those. The other question was, what about the long-term 0 calcium in diabetes? Should we shorten the period of reassurance? Some studies suggest 5, not 10. If so, would you recommend a second calcium after 5 years? What's your suggestion? So again, a lot of questions here. Now moving the discussion to diabetes patients, I think your question's more related to asymptomatic individuals. As you look at the guidelines right now, of course, although the 2018-19 guidelines took the first big step in reassuring individuals with a calcium score of 0. They are still a little hesitant as far as diabetes patients are concerned, and there are ongoing studies that in the next 12 months will give us some more insights. For patients who are coming with chest pain, if they have a calcium score of 0, at what we have not yet seen any indication, at least from the PROMISE study, the confirmed study, or any of the other long-term cohorts, that an absence of a calcium score of 0 for asymptomatic patients would offer less prognostic. Because the question really is, are we going to pursue with more advanced imaging? Do they have significant coronary artery obstructive disease that is that can indicate why they're having chest pain? So I don't think at this moment we have enough data, but again, that just highlight the uncertainty. We need to answer all of these questions, but so far the data applies to the diabetic patients too. Any other questions here? Are there any calcium scores for the mammary artery? If yes, is the score useful for screening permeability of this graft? An interesting question. I have no idea. I don't think so that we have yet looked at mammary arteries or the graft, Lima graft calcifications. So one of the questions is, what's the feeling of calcium in smokers and family history considering guidelines? Great questions, and again, I would like to refer those guidelines are basically referring to asymptomatic individuals, and so far they have asked us not to provide the same reassurance. However, data coming from Jaydeep Patel's and Bill McCoy's group from Hopkins clearly showed that individuals with a calcium score of 0 with a family history have almost the same prognostic value as somebody without a family history, and well below the threshold that one would consider a long-term statins. And even in recent years, patients with heterozygous FH, Raul Santos group have shown that at least in the short period of time, family history and elevated lipids, you have a significant favorable prognosis. And Mesa in a 13-year follow-up suggested the same thing, that even in severe hypercholesterolemic patients, a power of 0 holds. Now the question is whether that would hold true for asymptomatic patients. I don't really see a reason why not. Another question off topic, but carotid IMT has been shown to be not helpful in predicting risk. Want to know what are your thoughts as many for these executive screenings? And it's an interesting question. I think we are in uncharted territories where, as far as the prognosis in middle-aged individuals is concerned, we have found that CMT may not offer much prognostic value above and beyond a coronary calcium test. However, at the same time, studies have suggested that there is some valuable information that may identify those who are at slightly higher risk for strokes. And especially Dr. Fuster advocates that in the younger individuals, we are talking about not only coronary atherosclerosis, but multivasculature, any atherosclerosis indication that can help us identify those who will be at risk in the next 10, 20, 30 years is useful. So in these circumstances, in the young population, I think carotid IMT has potential, whereas the highest value for calcium testing truly holds in those with the middle age and the elderly. So it's been a great question so far. Again, if you have any question, you can text us DeBakey to 37607, all live. Should patients with normal stress get a calcium scan for risk stratification? And the answer is an absolutely yes. I think anyone who's undergoing a stress myocardial perfusion imaging, actually not after a normal perfusion, actually before a study has been done. Because as we have clearly shown, it will add value at 4 levels. The first thing is, if you have a calcium score of 0, based on shared decision making and based on patient risk, you can even decide to forego a stress myocardial perfusion imaging. But if you get a positive calcium scan, it is going to help in the interpretation, be it subjective or objective diagnostic for ruling in and ruling out significant coronary artery disease. It will provide you more prognostic information that can guide intensification of preventive therapies. And actually in real world we have seen is if you get those information together in the scenario of a normal stress test, presence and a higher burden leads to significant downstream initiation of preventive medications, which is likely going to be the main reason of improving outcomes. The question is, are any centers using calcium score alone in ED? If not, what do we need to do to get there? This is the most burning question. In spite of the fact of significant evidence, I think the main challenge we have that none, in my view, EDs in this country are using, doesn't mean we shouldn't be. It boils down back to the guidelines. I think so. Now the guidelines need to take a step back and acknowledge the power of zero. We have enough data to at least get it a class 2A recommendation. We have clearly now seen that an absence of a calcium score of 0 offers a reassurance that is 4 times better than a stress myocardial perfusion imaging as well as a stress echocardiography. And if the guidelines and our ED physicians are reassured with a normal stress test, stress echo, I think so they should be 4 times more reassured for that. So I think so the first step needs to happen is the next guidelines, they need to accommodate and organize all of this data to give it a class 2A recommendation. Then the other thing is we'll continue to debate and deliberate on this issue. I think so centers like Methodist, where we have employed this technique, can take the lead with our partners across the country in developing a randomized control trial where actually individuals with a calcium test of 0 in the low risk can be sent back home and we can assess their 30-day safety data. I think so all of these steps will eventually lead us to move in that direction. And thirdly, if you ask Dr. James Udelson, who was one of our grand round speaker, and I posed this question to him, his answer was clear. The day we move into value-based financing and we get a certain amount of dollars to manage patients with chest pain, we will be wise enough to use the most effective, the most cheapest gatekeeper. And in that scenario, I think truly will see adoption of calcium testing as a gatekeeper. And so far the discussion has been fantastic. I wish it would have been more live. We could have, but if you have any other questions or any thoughts, please do share with us. Waiting for the questions, I truly want to thank everyone who joined us today for an interesting discussion and the opportunity to present the part 2 of the power of zero. While we have seen that it is now well established and acknowledged by the guidelines, with everyone's help, I think so there is going to be a significant value in the next 10 years of the power of zero. And I hope, and I'm optimistic that as we all get together and get more reassured and where we are focusing on doing more with less, the more we move into that direction, the more we'll acknowledge the power of zero. But again, thank you so much for joining us today live from DeBakey Cardiovascular Disease Studio. And keep tuned in for next week's series on the multimodality imaging conferences. And by the way, don't forget to follow us at DeBakey CV EDU on Facebook, Twitter, LinkedIn, and YouTube. Thank you so much.